Well, good afternoon, America. I'm Dr. Randy Fink talking to you live from CNY Fertility in Colorado Springs. I am the clinical director of IVF services here at CNY Fertility in Colorado, and also the medical director at CNY Fertility at the Miami Center of Excellence in South Florida. And gosh, we sure are happy to have everybody joining in here. I would like to press the button and say wave to everybody. Gosh, too many fingers and not enough places. Hi, Miley. Nice to see you. Nice to see everybody. Gosh, we're so happy to have you here live in our CNY Nation and, of course, actually internationally via internet. We do this every Tuesday afternoon at 4 o'clock, and so certainly I'm glad to have you all with us. My eyes are kind of going to be going in a bunch of different places because right here we've got Facebook. We've got LinkedIn. We've got a couple of different Instagram accounts here, and we've got YouTube. Hopefully, all of social media. Hi, Kate. Hi, Ashley. Glad to have everybody here. Hey, Brandis. Brandis is watching. I can push the wave button there. Also, special hi going out to, let's see, Lauren and William in Miami. Of course, my dear friend Amber in Kentucky. Also, my friends in Miami, Barbara and Adrian and Alexis. Thanks everybody for joining us here. Again, every Tuesday at 4 o'clock, we do Fertility with Fink and Friends. I am my only friend today. I have no friends. I just, you know what, the sound of Fink without friends didn't have the same. It wasn't really the same. It didn't have the same vibe as Fertility with Fink and Friends. Sort of like our Miami Center of Excellence. Well, we call it that because the name Miami Center of Mediocrity had already been taken. So, we kind of needed to come up with something catchy. But here we are to answer all of your fertility questions today. Questions about women's health, really anything that you want to talk about. Hi, Stephanie. Hi, Vivian. Hi. Oh gosh, Jen Chica. Hi, Amy. Hi, Grace. Hi, Mrs. Pittman. Gosh, and it looks like Chloe said Brandis and I did your retrieval and a day 3 transfer, and now you're pregnant. Gosh, that is the best news. And I have to tell you, this week was also really very special because, and hi from Los Angeles. I'm glad to have you. This week was special because. To be honest, it's always very special when we get to see such really wonderful people and help people to get pregnant. And this week was great and I see actually William just joined. I already said hi to you, but you weren't on. You missed that part. You were tardy. Yes, Andre, it was a day 3 transfer, as what I believe was said. But this week, we had some folks bring a baby by to see us who we had helped to create. And I have to tell you, that just makes all the difference in the world. It becomes such a pleasure. It's such a gift. Just like, to be honest with you, it's a great gift for you to be with me here today and for you to put your trust in us here at CNY. In order to help you with your family goals. And I see that Lauren joined too. And hey, Lauren, you missed it because I already said hi to you. I gave you a shout out at the beginning and you joined late. So now you're in trouble. That day 3 transfer seemed to be something that people wondered about. People do get pregnant from a day 3 transfer every day of the week here at CNY. So I want to just mention a little something about that. Because it's a common question, and then I've got another little question that came in here to my email this week that I want to address that we've talked about once before. It has to do with Pap smears, so we'll talk just a little bit about that. But the question is a day 3 versus a day 5 transfer, and there are many people. I will tell you that there are a lot of practices in the United States that will say we will not do a day 3 transfer. We will only do a blastocyst transfer. A blastocyst is when that little cleaving or dividing embryo becomes a multicellular little functioning machine. And that's typically by day 5, but sometimes also day 6, sometimes day 7. That's a blastocyst. And we do know that having a blastocyst does increase the probability of you being able to get pregnant. However, if we are limited in the number of embryos every day of the week, all day long, we would rather see an embryo going inside of you where it may have the chance to grow, whereas it might not grow in the lab. And if that's the situation, put that embryo in you. If we're limited in the number of embryos, we usually suggest either a day 3 freeze or a day 3 transfer. So our typical protocol is 5 or more embryos. We recommend you do a blastocyst, let them grow to blast. 4 or fewer that you do your freeze or your transfer on day 3. Yes, it's a little less likely with a day 3 embryo that you will get pregnant, but it doesn't mean that you're not going to get pregnant. And that's only because nature helps to select out some embryos when they continue to grow to blast. And if they continue to grow to blast, then that's why we say they're more likely to get you pregnant. So don't fear the day 3 embryo, as I'm fond of saying, if you have joined us before. I also want to give a special shout out to my beautiful mom and dad who are, if they're not watching today, they will be watching the replay. My mom and dad in Mobile, Alabama, beautiful Lower Alabama. My folks live in LA, is what we say, Lower Alabama. So glad to have everybody here. Well, we will hopefully be here till close to 5 o'clock Mountain Time, which will be 7 o'clock on the East Coast. So let's see if we can start to get to some questions. The first question again went back to the Pap smear. And the question was, is my abnormal Pap going to have any effect on my ability to get pregnant? We do feel like folks should be up to date on their general medical screening. The Pap smear is a screening test for pre-cancers of the cervix. Most of the time, I will say that the abnormal Pap smear is a very common finding in general gynecology, and it's a source of tremendous worry for people, but it rarely has any great significance. The issue of cervical cancer in the United States is fortunately very low, and the reason for that is because we're pretty good at finding these precancers and either following them or treating them such that they do not progress to cancer. So I would say by and large, for most people with an abnormal Pap smear, it is absolutely a nuisance to you and not a particular danger. Again, an abnormal Pap is a nuisance, but not a particular danger. And if that's the case, then no, it doesn't really have anything to do with your ability to get pregnant or to stay pregnant. So that's good news. I appreciate that question. I'll say hi to Alexis, who, again, you know what? Everybody's joining on my Instagram over here. If you don't follow me on my Instagram, please feel free to do so. It's Dr. Randy Fink, or actually, no, I'm sorry, it's not. It's Randy Fink MD is my Instagram account, and we try to keep some interesting information on there. But I said hi to a bunch of people over here on my side who joined in late, including you, Alexis. So you know what? You're going to the principal's office along with Lauren and William. So I just don't know what else to say. Well, let's start to get to some questions here. Let's go over here to the Facebook and LinkedIn side. And this comes from Amanda Joe. And Amanda says, oh, hey, you did it. Your beta was positive yesterday. Woohoo! Well, we're praying that everything keeps progressing, and we are right there with you. It is great to hear these stories about a positive pregnancy test. And for those of you who are waiting to get your positive pregnancy test, we are waiting right there with you, and we can't wait to hear the good news. Okay, how long after having COVID should one wait to start a frozen embryo transfer? And that comes from Tani, I think, if my glasses can see. And that's a really good question. If you were around I think it was last week, Brandis Montez, our wonderful nurse practitioner here, was planning to do an egg freezing cycle. but instead got COVID. So fortunately, COVID is now one of those things that is also really more of a nuisance. And gosh, it wasn't long ago. We all know that COVID was a very different story. So it's kind of interesting even to look back at some pictures from a year and a half ago to see that we were all going into public places wearing masks, never without a mask, and um, and just fascinating to see how times have changed. But what we learned is that there's some conflicting data as it pertains to COVID and fertility. And that is that, oh, and let me just say over on this side, hi, Anna. Nice to see you. I was going to ask you to be on the show here with me today, but you decided not to show up to work. So I'm sorry, I digress. The COVID question, as it pertains to egg quality, may have something, there may be some effect on egg quality. So Brandis, in her research, decided not to do her egg freezing cycle, her stimulation and egg freezing, until about 90 days after COVID, because there's some data to suggest that it takes about 3 months for the body to recover from the inflammatory side of COVID, and that can have some effect on egg quality. There wasn't so much data about embryo transfer. So my feeling is that if you have recovered from COVID, you're no longer positive, and you're feeling normal, that there really isn't a particular delay that you need to await in order to do your embryo transfer. I think it's probably fine. So let's see what else here. Oh, Waleska's going to be here on Friday for a retrieval. We can't wait to see you. What else we have? Crystal says in her last retrieval, she got 8 embryos, but only 2 were graded very good, and the rest were poor and unfortunately ended in miscarriage. Well, this does bring up a very good point. There are a lot of things that can stand in the way of an embryo trying to grow and become healthy. But embryo grading should not be one of those things. And if you've followed along or if you've talked with any of us before, you've probably heard us say that the embryo grading is a beauty contest. So embryo grading was developed really so that an embryologist could look under the microscope and use a series of descriptors based on what they see in an embryo in order to make some sort of grade about the embryo. Now, most of us have been through high school or certainly through grade school where we know that you get a grade in a class, and that grade tells you how you've done relative to everyone else in the class. That's not what embryo grading is. So I always tell people, okay, so you got an A in English, and that means that you did better than most people in the English class. But you got a C in physical education in your PE class, so you weren't as much of a jock as you thought you were. Other people did better. Some people did worse. You were kind of right on the average. That's what we think of when we think of grading. So we would expect then when you come up with a grade of an embryo, that there is going to be some correlation of that grade with the outcome. But it is every day of the week that we see a poorly graded embryo may result in a beautiful, perfect baby, or a very highly graded embryo may sadly result in a miscarriage. So the whole purpose of the grading was to try to determine, can an embryologist look at an embryo and tell us which of the embryos are normal or chromosomally normal from looking at them? And the answer to that is no. So we know from all the folks who do PGT testing that with PGT, you may have a poorly graded embryo that is chromosomally normal, while you have a very highly graded embryo that has a complex chromosomal abnormality. So in that situation, I wouldn't really recommend that we focus too much on embryo grading, even though it's very hard not to, because we all want to know where we are relative to everybody else in the class. So there was a question I saw over here about the birth control. This comes from Arath10. Can you talk about when a birth control with immediate retrieval cycle is recommended versus no priming meds versus estrase, nervous about suppression. Okay, so let's talk a little about birth control as it pertains to IVF in general. There are some practices that batch their IVF. And so that may be a situation where they have an embryologist only, let's say, 2 weeks out of the month, or they have their anesthesiologist, their anesthesia provider, a week or two out of the month. And so they will put everyone on birth control in order to get all the women on the same cycle so that they can do their retrievals all within the same 2 week period or 1 week period, or however many days it is that they have their staff available. And that leaves the rest of their month to do things like monitoring and consultations. But they're restricting their retrieval periods to a certain amount of time during any given month. And that's the reason really many practices will use birth control. At CNY Fertility, we are open every single day except for Sunday, but we are doing retrievals and transfers every single day except for Sunday. So we do not batch our cycles like that, but there are some circumstances where we will recommend people be on some birth control. Sometimes it has the ability to synchronize the follicles. That is, it may take eggs of a different size that we see in the ovary and allow them all to kind of quiesce and get themselves to the same position so that once we start a stimulation with the stimulation medications, that the eggs grow at a similar pace and all end up at a similar size. So that's the most common use for birth control. Priming is really a different story. So priming is when we give you medications in order to try to affect the quality or the number of the eggs. And so we'll commonly use estrase. Estrase is estrogen or estradiol. Typically along with some progesterone as well to help to balance that out. Estrogen and progesterone are the language that the ovaries speak. And so by giving you some extra estrogen, it increases the blood flow going to the ovaries. It increases the general juiciness of the ovaries and may help us to retrieve eggs when that time comes, if that's potentially an issue. Some other things that we use to prime an ovary, we use some omnitrope. Omnitrope is human growth hormone. We also typically use some low-dose naltrexone. Low-dose naltrexone is one of our immune modulators. It stimulates your body's endorphin function, and the endorphins also increase blood flow to the ovaries. So that may help us with egg quality. And really, it's a great thing to do whatever we can to increase the blood flow going to the ovaries, so that especially if we're trying to deliver something like growth hormone, which has the ability potentially to turn the clock back on us and to make us have more healthy eggs, the body has an ability to get that medication there by way of that blood flow. So I usually prefer estrase and progesterone. Natural progesterone is called prometrium or micronized progesterone. I typically prefer that over birth control because you're right, birth control can really completely suppress the portion of the brain that's controlling the hormones and sometimes can leave a little bit of a delayed effect after that. But we often use birth control, as I said, to synchronize a cycle, synchronize the eggs, or to batch a cycle. Arath 10, I hope that helps. Hi, New York baby DJ. Nice to see you. Which protocol do we typically use for a patient with PCOS and an elevated AMH? And you ask some very good questions there. And so let's talk a little bit about that. The AMH, as you know, is the anti-Mullerian hormone, and that's a blood test we do that tells us about your ovarian reserve. When that number is above a 5, then we typically believe that your ovaries are going to respond like polycystic ovarian syndrome, which means, now it may not mean that you have polycystic ovarian syndrome, which is another conversation entirely about the specific diagnostic criteria for PCOS, but It's a very broad term. There are a lot of situations that can fall into what we'll call PCOS. And when the ovaries respond like PCOS, that usually means they pay very careful attention. They're watching very closely to that stimulation med, and oftentimes you get a very robust response. And so, for people with PCOS, for people who have a high AMH, and oftentimes for people with a higher body mass index, we typically think about going lower on the stimulation dose. Now, why is that? Well, most of the time, a stimulation dose of the medication we're going to give you is generally going to be based on your age. So, if we don't know anything else about you except for your birth date, the choice of how we're going to use the medication to stimulate your ovaries for IVF is really going to be based on how old you are. If we know that your AMH is above 5, it suggests that you may have a very robust response. So we are more apt to want to lower that dose so that we can keep you from getting hyperstimulated. So hyperstimulation happens when you make too many eggs. So if you remember, we've talked about inside the follicle in the ovaries, and of course the follicles are the little, we'll call it the egg house, those little black spaces in the ovaries when we do an ultrasound. Those follicles are lined by cells that are called granulosa cells. The granulosa cells are what make your estrogen. So at any age, the estrogen is coming from the granulosa cells in the ovary. And so when that estrogen level gets high, that's when we start looking at risk for ovarian hyperstimulation syndrome. It can cause you to retain water. It can cause you to be really bloated and not feel well. So oftentimes when people who are hyperstimulated show up for us, we will frequently give them some extra pain medication because the ovaries get very large. And so it's hard to walk around with basketballs on the inside. In fact, if you've been here with me in Colorado Springs and you've been hyperstimulated, I may have asked you what airline you flew, because depending on which airline it was, they may or may not have allowed you to carry your ovaries in the cabin with you. You may have to check them as luggage because they get so large, unless they can be placed safely beneath the seat in front of you, or in the overhead compartment. Just kidding about that. Ovaries can get very big, and when they get big, obviously they're uncomfortable. When ovaries get big, that can also make you nauseated. So we typically give you some medicine for nausea. They can cause you to retain some water, and so everything slows down. So that causes bloating and gassiness, but that extra fluid retention on the inside can also be around the heart. It can be around the lungs. It can be around the brain. So fortunately, we've really learned how to, in general, prevent ovarian hyperstimulation syndrome, at least the very severe ones where folks get really sick, but occasionally somebody does end up in the hospital with ovarian hyperstimulation syndrome. I will tell you the more common thing that happens is that people are bloated and uncomfortable and end up going to an emergency room because they're worried. Maybe they feel short of breath because, think about it, if you're really bloated and the ovaries are really large, the way we breathe is that our diaphragm pulls down, and that's what sucks the air into our lungs. Well, if we're super bloated here, it's hard to get the diaphragm to feel like it wants to pull down, and that can lead you to feel short of breath. And let me tell you what happens when you call any doctor's office and tell them that you're short of breath. You're going to get sent to the hospital. Why? Because we're on the telephone. I can't tell you that, why you're short of breath. I don't know what your oxygen level is. We don't know what's going on. So the safest place in that situation to be is where you can be evaluated. But by and large, most of the time when that happens, folks just have large ovaries. They're uncomfortable. But I will tell you the one thing that I have seen consistently that I would really like to share with everybody, if no one else has told you, I think this is one of the most important things that you can know going through the IVF process. And it's 2 words: stool softener. Why? Because we are all full of stool. right? And when we get bloated and we get pain medication, especially when we get some anesthesia as it pertains to having an egg retrieval, when we get swollen and big ovaries and we have a retrieval, constipation becomes a bystander in just about everyone's life. And so if you realize 5 days later that you haven't gone to the bathroom, that's probably a good reason that you feel even worse. So I generally recommend folks, even under the best of circumstances, keep really on top of how you're going to the bathroom, because constipation will catch up on you and can really make you uncomfortable. So is there a best protocol for PCOS? Well, there's not one specific protocol. There are many, but in general, with PCOS and a high AMH, we tend to go for lower doses so that we can avoid keeping you hyperstimulated. It's not uncommon in a patient with PCOS that we might retrieve, gosh, I think my record was 140 eggs from somebody. And trust me, that's a lot of eggs. But quantity is not quality. Many of those eggs won't fertilize. Many of those that fertilize will not be normal and will not continue to grow. So we would much rather focus on getting you fewer quality eggs than getting you some huge quantity of eggs. So let's see here. Alexis is asking about not starting until June. Let's see what we said there. For hopes of Sarasota becoming full service, and it will. You did your pre-labs and your AMH came back at 4.16. That's a very good number. Alexis is 29, so that's a really good number. That tells me that your ovarian reserve is good. Does that mean that you have PCOS? The answer is no, but I would suspect that you are probably going to respond really well to your hormones, to that stimulation. So if I had someone with an AMH of 4 versus an AMH of 1, and she was 29 years old, the person with the AMH of 1, I would give an age-appropriate dose for someone in their 20s. With that AMH of 4, almost 4.2, I would be tempted to drop that dose lower than the age-appropriate dose in order to keep you from getting hyperstimulated and to give you good quality eggs, as we said, rather than quantity. But that's a great number to start with, Alexis, and congratulations on having that. Hopefully that's going to make everything a lot easier for you. Yep, I'm told that Sarasota is going to be online for full service by the summertime. But meanwhile, I have to tell you, Colorado's a pretty nice place. Just saying. Okay, what else do we have here? Let's see. It looks like Iandre, who I believe is in Los Angeles or Lower Alabama, potentially, asks about protocol for a day 3 frozen embryo transfer, and also asks about natural or modified natural cycles. And so that's a good question. So let's talk about it. If you haven't had the talk, if you haven't heard about it, let's be very factual about a medicated cycle versus a natural or a modified natural cycle. Now, the first thing I'll tell you is that the medicated cycle has been the standard of care in IVF since IVF was invented. And basically, that's where we give you 6 to 8 days usually of estrogen, and that estrogen causes your lining to grow. We do another ultrasound to show that your lining is thick enough, and that's called our timing of progesterone start. So once you start your progesterone, you get 6 to 8 days, you get 6.5 days of progesterone, after which you have your embryo transfer. That's a medicated cycle. The bread and butter, the cake of the medicated cycle is very much the same. It's estrogen and progesterone. Now, we add a little icing to that cake. And the icing is our immune protocols, because we know that there are some folks who are not getting pregnant because of autoimmune reasons. Their own immune system is trying to stand in the way. Well, so we do some different things with the immune system. We do intralipid infusions, typically a baby aspirin. We're on some prednisone. We have our antihistamine core. Sometimes there's Lovenox, which is a blood thinner. Sometimes there's Neupogen or Plaquenil or Prograf or some of the other medications that go along with the higher level of the immune protocols. Those things are icing. Do you have to have a cake with icing? No, you don't. Some people don't like to have cake with icing, although frankly, I don't understand that, but I just like cake. You can have a cake without the icing, sure. And could it work to get you pregnant? Absolutely, 100%. I happen to think that cake tastes a little better with some icing. So, by adding that icing, that immune protocol, we may be able to help some folks who have an immune issue that we may not be able to recognize. We may help them get pregnant or stay pregnant by using that immune protocol. And that's the reason we add it on. So, sometimes people will call me and they'll say, "What can I do differently with my medicated transfer protocol?" And the answer is, well, the protocol is the protocol, right? The cake is the cake. Um, the question is, what's the icing like? And can we do something different with the icing? Now, if you had asked me maybe 9 or 12 months ago about a natural cycle, I probably would have told you, well, the natural cycle is, it got a lot of sort of fame and fortune because of the internet and frankly, because of Facebook. People were talking about it. And so it became popular and people thought, well, maybe that'll work for me. And inevitably, what happens is that someone will write on social media, well, this is what I did and I got pregnant. And then other people will read it and say, well, if that worked for her, it ought to work for me too. Well, no two people are alike. So I would caution you to be very careful with that kind of information, coming from social media, because people aren't alike and you can't really make comparisons based on one person's history or one person's story. So a very important consideration. But I used to say that, well, the natural cycle is no better or no worse than the medicated cycle. The medicated cycle is our standard of care. And again, probably 90% of our patients will use a medicated cycle for transfer. But now what we know is that the natural or the modified natural cycle probably has a little bit higher of a pregnancy rate in some situations. It has a little bit lower of a miscarriage rate in some situations, and it certainly decreases a certain type of pregnancy complication later on, specifically blood pressure related complications in pregnancy. So the way the natural cycle works is just like you are trying to get pregnant yourself. You get your period, we allow your body to start developing a follicle. Although some people do not ovulate on their own, or they won't develop a follicle on their own, and that's typically anovulatory patients or those with polycystic ovarian syndrome. So we can give you a little medication to make sure that you are going to release the egg, and that medication is usually letrozole. So if that's the case, we give you some letrozole. We watch the egg start to develop, the follicles start to get bigger. Well, that follicle is lined by granulosa cells, and the granulosa cells make estrogen, right? So that's how you make your own estrogen. And so rather than giving you estrogen from the outside, your body is going to make that estrogen from the inside. Well, we can follow the hormone levels and we can look at the follicle. And when we see that follicle is mature, we can trigger you to release it, trigger you to ovulate. And the timing of the trigger sets the timing for when you will have your transfer. So that way we can try to make sure that it's not going to happen on a Sunday, because again, we're not open on Sundays, unfortunately. So once you've triggered, that little estrogen making apparatus becomes a progesterone factory. And when you are making your own progesterone, that seems to be the magic sauce. That's what seems to help folks get pregnant, help folks stay pregnant, and certainly to decrease the blood pressure complication risk later on. So I'm a big fan of the natural or the modified natural cycle. In a natural cycle, you do that all on your own. We don't give you any medication. You risk the timing issue with that. You risk that, oh, that, the watch pot never boils. You risk that the timing doesn't happen the way you want it to, or that it may not, you may not develop a follicle in a timely fashion. So, plus or minus the letrozole. Certainly, if you ovulate on your own, I don't feel like you need to use letrozole. But triggering, that's a modification to a natural cycle so that we can give you the right timing. Since many people do have to travel, it helps us to know when that's going to take place. And we still give you some extra progesterone because your body really does need more progesterone in order to help to maintain the pregnancy. That's what a natural cycle is versus a medicated cycle, and you have the choice. So if you're doing a medicated cycle, all the variables are out. We are controlling everything. So we can pretty much from the beginning tell you when it's probable that you're going to have your embryo transfer. There's a little bit more variability when you are doing a natural cycle because we're depending upon your body to do what it's supposed to do. So hopefully that answers the question. As I said, I am a fan of the natural or the modified natural. Looks like Gwen is asking, do I have a recommendation for assisting with implantation? You struggle, we seem to struggle with a pregnancy that implants successfully. So implantation is the process whereby your embryo is taking up residence inside of the uterus, the uterine lining. So there are some natural things that you can do to improve implantation. And the most obvious of those is vitamin D. Vitamin D, of which we are almost all deficient. So even, when I was practicing in Miami, my lifeguards from Miami Beach who spent all day out in the sunshine still were vitamin D deficient. We do get our vitamin D from the sun. We don't spend as much time in the sun, I think, as our ancestors did. So there is a sort of a pandemic of vitamin D deficiency. So supplementing with vitamin D is something I recommend. Usually vitamin D with vitamin K, and the liquid form of vitamin D with vitamin K is really the best form to be able to get vitamin D. And I recommend 5,000 units a day of vitamin D. You may look at your multivitamin and it may have 1,000 units. It really doesn't do very much. There is a big thing in the primary care world where they will prescribe you, if you're deficient in vitamin D, a tablet that you take once a week that's 50,000 units of vitamin D. And to be honest with you, I don't find that works very well either, because the body doesn't really have the ability to absorb that much vitamin D at once. I think vitamin D is probably the best thing that you can do naturally for implantation. So I hope that helps. Crystal over here on the CNY Instagram side said, my first egg retrieval, I was 24, almost 25, and only got 18 eggs. Well, you say you only got 18 eggs. I think that is a fantastic result, because the data shows us that anything more than 15 eggs retrieved really doesn't improve the outcomes. Well, Crystal says, now I'm almost 30 and we'll be doing a second egg retrieval this summer. What's the chance of me getting more eggs, or will I end up with less? Well, to be honest with you, doing an egg retrieval in your young 20s suggests that you will probably have a very robust response. And certainly as we mature, the quality of those eggs will start to change, because as we mature, the DNA in those eggs becomes less stable. And that's why in general, it's harder for us to get pregnant the older we are. Now, 30 is by no means old, but I would tell you if we were having our consultation together, I don't need you to have 18 eggs. 18 is probably more than you need. I would focus on trying to get you fewer, but of higher quality. In many situations, I would say, I don't care if you get 5 eggs, if they're 5 good eggs. If those 5 good eggs will make 5 good chromosomally normal embryos, that will get you pregnant, then that is a win for both of us. Nevertheless, based on what you're describing, I would give you an age-appropriate dose, but my guess is at 30, with an age-appropriate dose, you probably won't get 18 eggs, but that's okay because we don't need you to get 18 eggs. So, Crystal, best of luck to you. Fingers crossed. Well, let's see what we have over here. Deanna is asking, what exactly is an HCG wash and what are intralipids? And are these things that we should do before a transfer? Well, it's a good question. The HCG wash and the intralipids are both things that are part of our immune protocols. An HCG wash is where we take the HCG hormone, which is the pregnancy hormone. Right? So when you go get your blood test for pregnancy, it's for what's called a beta HCG. We commonly just call that a beta. When you do a urine pregnancy test, it's testing for the beta HCG. But we use HCG hormonally for several things. We use it for a trigger of ovulation because in the body, it functions like the hormone we know as LH, luteinizing hormone. So, when we put LH or HCG, the pregnancy hormone, in or on the cells that line the uterus, the endometrium, it turns them on. It flips the switch and it makes them start creating some of the proteins and some of the biochemicals that are necessary for implantation. So an HCG wash improves implantation. So if you have the ability to do an HCG wash before your transfer, I would strongly recommend it. All right. HCG wash is typically done in the 1 to 2 days before your transfer. So if you're traveling, it often means you need to get here a little bit early because we don't typically do it on the day of transfer. We don't want to have the extra fluid there on the inside. And intralipid is an IV infusion of ultimately what's kind of like having an IV keto diet. It's a fat infusion that goes through the IV, and it's just very profoundly anti-inflammatory. So again, if you're able to do it, I would strongly recommend it. So hopefully that helps you out there, Deanna. Thanks so much for being here. Well, it's about 42 minutes after the hour, and you're watching Fertility with Fink and Friends live from CNY Fertility in Colorado. I'm Dr. Randy Fink, and we'll be here for about another 15 minutes or so. Please throw your questions out. I'm going to try to get to everything I can here. Erica is telling us that she has an AMH of 0.15. So that is what I would call a diminished ovarian reserve, which is consistent with being 42 years young. Would I choose a low, moderate, or high dose stimulation? Erica, that is a brilliant question. And so I'd like to address that. Is there a difference also between Gonal-F and Follistim? To be honest, Gonal-F and Follistim are both what are called recombinant FSH. So FSH is follicle stimulating hormone. They really are both the same. They are fairly comparably priced. Sometimes insurance will cover one, not the other. Sometimes insurance will cover something that's bundled with it. So therefore you end up getting one versus the other. But in terms of outcomes, they are fairly similar. Both of them come in a pre-filled auto-injector syringe. The way the syringe works is a little bit different between the two of them, but really the way they work as FSH, follicle stimulating hormone in your body, is quite similar. So you should not be alarmed or concerned about using Gonal-F versus Follistim. It's kind of going to be whichever one is easiest for you. As far as low, moderate, or high dose protocols, let's talk about that because I think it's really an important thing. And if you've been through IVF or if you haven't had a consultation with us yet and you're thinking about it, this is something that's going to come up. So let's try to settle it now. The classic wisdom with IVF has always been that if you have a diminished ovarian reserve, for whatever reason. Maybe it's based on age alone. Maybe it's based on an autoimmune function. Maybe it's based on no reason that we can understand. The classic wisdom was that we want to take as much medication as we can get and pour it on your ovaries so that we can try to get your ovaries to respond. The problem with that is that sometimes that works against us. Instead of getting a very robust response by using huge doses of medication, sometimes your ovaries kind of go, and they actually do make this noise. They go, kind of like that. They do make that noise if you listen really closely. The ovaries don't know what to do with all that stimulation, and so they shut down. Instead of getting a really great response, sometimes that means we get no response at all. And that's really a bad thing, especially when you've spent a boatload of money, because the medications, as you know, are not inexpensive. So using very high doses of medication may have an altering effect in what you expect it to. Instead of getting a great response, you get a very poor response. So we at CNY tend to philosophically believe that you do better with a lower dose. Now, that information actually comes from Europe. And what's the significance of Europe? Well, in Europe, the governments cover IVF for people, but the governments don't care if you get 20 eggs or if you get one egg. They say, we're paying for this, so this is the dose of medication that you're going to get. And it's a low dose because they don't want anyone to be hyperstimulated because they have to pay for that hospitalization as well. So they use mini doses of IVF, or really what we call the European dose. And what we have learned from hundreds of thousands of cycles in Europe is that using a mini dose in the case of diminished ovarian reserve will typically give you an equivalent response as what you were going to get, or I should say an equivalent outcome as what you were going to get if you were using a very high dose. So let's say we use a high dose and maybe we get, let's just pick a number, we get 10 follicles. And of those 10 follicles, you get 6 eggs. And of those 6 eggs, you get 4 embryos. Just picking numbers there. Well, instead of 10, 6, and 4, you use the mini dose. You're not going to get all 10 follicles that you would at the very high dose. And maybe you're only going to get 5 eggs instead of 6. But at the end, you're going to get 4 of them that fertilize. So that is an equivalent outcome with the lower dose of medication. And with that lower dose of medication goes a lower cost. And along with that lower cost goes certainly a lower side effect profile. So, Erica, I would 100% do a mini dose protocol for you with an AMH of 0.15. And we have been very successful with that. Dr. Kiltz is a champion of the low dose protocols because frankly, I would much, and I would tell you as well that in the case of an AMH of 0.15, we know that it may take more than one cycle of IVF for you to get where you want to be, to get the number of embryos that makes you feel comfortable and us feel comfortable that we're going to be able to get you a baby. I would much rather see you be able to do more cycles of IVF with a lower dose of medication than spend all your money on one cycle of IVF and a huge high dose, because it's not unheard of to potentially spend $8,000 to $12,000 for high dose stimulation with medication. So that's why mini dose is probably the best choice there. So thanks, Erica, for that question, and best of luck to you. Let's see what else we have here. For those who I have missed, I apologize, but we've got 10 more minutes or so. So let's see what we can do here. Let's see here. Looks like Natalie. Hi, Natalie Foster on the CNY Instagram side. Thanks for being here. I intended to go with a banked donor egg right away in March, but have been advised by donor team to use a fresh donor egg. Well, good question there too. So what she's asking about is that when you're going to use donor egg, which I think is a marvelous thing when we need to do it, and we've talked before about epigenetics, and I have a little video on the CNY Instagram about epigenetics, and so I don't want to be repetitive, but it really goes to prove to us that that embryo being inside you, even from a donor egg, is 100% your baby. When we're using a donor egg, we have the option of either using a banked egg, so that's an egg that's already been retrieved and frozen and is in one of our cryo tanks, which we can simply then thaw and fertilize for you with the sperm that you are providing. That is a banked donor egg, as opposed to retrieving the egg fresh from the donor and then going to retrieve them. If you have the ability to do a fresh donor egg, I think that's a better idea. And why is that? Well, we've come a long way in terms of egg freezing. So certainly in terms of freezing embryos, we know that probably 97% of embryos will survive being thawed. Of eggs, we think probably 80 to 90% of eggs will survive being thawed. But if we have fresh eggs that we're going to fertilize, there is zero risk to freezing and thawing because they're not frozen. You're going to have a higher probability of success freezing an embryo than you are freezing an egg. And so if you buy a package of frozen donor eggs, there is a and most people typically buy either 6 or 8. I think it comes in those kinds of increments. There is always a possibility that when you go to thaw, let's say your 6 frozen eggs, that 1 or possibly even 2 of them may not survive the thaw. So if you can use a fresh donor egg, you alleviate that risk associated with embryo, with egg thawing and egg freezing. Let's see what we have here. Very, very low AMH. Is there any chance to get pregnant? I would never tell you that there's no chance. I can't tell you the number of people who I have met in my career who come to me saying they told me I would never get pregnant. Well, and then they're sitting there with a pregnancy. I would never say never. The AMH really only suggests how you're going to respond to the medications. So it may mean that we make some adjustments, and the adjustments that we typically recommend are, as I said, those using a lower dose protocol. But even a very, very low AMH still leaves you some possibility of getting pregnant, and it doesn't say anything about your ability to get pregnant on your own, only how you're going to respond to the medication. So let's see what we have here. Oh gosh, I see some. Would you suggest getting a sonohistogram after a D&C? This comes from Bree Bales over on my Instagram side. Thanks for being here. I'm dreading it and would put it off because the last one was really painful. Those procedures are not pleasant at all. I will tell you, well, I've got maybe some exciting news. I don't know if it's safe to say it yet because it hasn't been 100% approved, but I will say, well, I'll get to that in a second. To answer your question, I do feel like the uterine cavity should be evaluated once a year. Now, is it necessary to evaluate it just because you had a D&C for miscarriage? And I would say the answer to that is no, not necessarily. But once a year, I do think it makes sense to either have a hysteroscopy or a saline sonogram or a sonohysterogram in order to know that there have no polyps that have grown on the inside, or that there's no scar tissue or fibroids or bands of muscle or anything else, because you've made a big investment to make that beautiful, perfect little embryo. And so we want to know that the place that that beautiful little perfect embryo is going to go back is just as beautiful and just as perfect as the embryo itself. So I don't think necessarily you need it because of the DNC, but if it's been more than a year, I do recommend that you evaluate your uterine cavity. Now, again, the saline sonogram or the sonohysterogram is different than an HSG. The HSG is the dye test, and that's the one that's done with the special type of x-ray where we're looking at the fallopian tubes to see that the fallopian tubes are open, and we're also able to see the shape of the uterus. That one is almost universally recognized as being a painful and uncomfortable test. Fortunately, it's a pretty quick test. We do a lot of them at CNY at all of our locations. So we're pretty good about getting them done in as easy and as comfortable a manner as possible. But even still, on a good day, it's still an uncomfortable test. We are working. If you happen to notice, my colleague Brandis created a video that went up a couple of weeks ago on the CNY Instagram side that was inside or behind the scenes at your HSG. And I will say that the response was very good to the information provided, but almost everyone said, "Oh my heavens, that was really an unpleasant test for me." So we heard that information and we are working towards a possible solution. We may be able to start providing nitrous oxide or laughing gas in our facilities to be able to alleviate some of the discomfort and the anxiety associated with these painful procedures, such as the HSG, sometimes an endometrial biopsy, sometimes a saline sonogram. This has not been perfected yet. It has not been fully approved yet, but Dr. Kiltz, in his great wisdom, has said he is willing to entertain it. So we're hopefully going to be able to push that forward so that some of those more painful tests will be able to get mitigated by a little something that you can breathe. It's been around for many, many decades and is extremely safe. Keep your eyes tuned to the social media because we will, of course, let you know once that becomes available. Well, let's see if I've got time for another question here. What is the Baby Gap 3 wants to know what's the optimal lining thickness for a frozen embryo transfer? There is some controversy. We like to see, some will say 6 millimeters, some will say 7 millimeters. I say really anything above 6 to 6.5 is ideal for progesterone start. We like to see what's called a trilaminar or 3-layer endometrium, which is where you see the top layer, you see the bottom layer, and you see the interface between them. And this looks like, I did this once before on a live because I was going to show you. It looks like my lips, and somebody took a screenshot of me going like that, and yeah, that's now there. They haunt me with that. So that's a trilaminar endometrium, and so that's what we look at for the timing of progesterone start. There are some people who have a slightly thinner endometrium, and sometimes we can actually look at the blood flow going to that endometrium and see that it's adequate, and that may be enough for you as well. So these are all great questions, and as always, it's been such a pleasure to have you all here. I sure hope you'll join me next Tuesday for Fertility with Fink and Friends, because I think I will have a friend next time, but we'll see if we can do what we can here to answer all your questions. Live from Colorado Springs, I'm Dr. Randy Fink, and we sure hope that you'll join us, and that here in Colorado or wherever you live, that CNY can help you with your family. God bless you all. Thanks so much for being with us, and we'll see you next week. Bye-bye now.